For nearly 2 centuries, medical science defined Parkinson's disease by what was visible on the surface, an isolated, rhythmic tremor resting in the hand, accompanied by stiffness and slowed movement. That clinical definition captures only the middle chapter of the condition. Evidence now shows that Parkinson's is a progressive, whole-body phenomenon that begins decades before a patient experiences any loss of motor control. At its core, the disease is a multi-system alpha-synucleinopathy. Alpha-synuclein is an abundant protein normally found in presynaptic nerve terminals, where it helps regulate the release of neurotransmitters. The pathology begins when these alpha-synuclein proteins misfold. Instead of performing their normal cellular function, the misfolded proteins aggregate, clumping together into toxic, insoluble inclusions known as Lewy bodies, which slowly suffocate and destroy the host neuron. Most cases of Parkinson's are idiopathic, arising from an unknown mix of age and environmental exposure. However, roughly 10 to 15% of cases are genetic. These mutations expose specific cellular pathways that are likely central to the disease, even in patients who don't carry the genes themselves. 2 primary genetic targets stand out: LRRK2, the most common mutation, and GBA1, the strongest known risk factor. Both mutations directly compromise the lysosome, the cell's waste clearance system. When the lysosome fails, the neuron loses its ability to clear out misfolded alpha-synuclein, accelerating the buildup of toxic Lewy bodies. Parkinson's is a slow, systemic accumulation of these toxic proteins. The evidence suggests it is not a spontaneous mechanical failure, but a failure of cellular clearance that predates the first tremor by decades. The initial misfolding of alpha-synuclein rarely begins in the brain. Post-mortem staging indicates that the pathology first takes hold in the peripheral nervous system, specifically within the enteric nerves of the gut and the sensory nerves of the olfactory bulb. Once established, the misfolded alpha-synuclein behaves like a prion. It travels across synapses and corrupts adjacent healthy alpha-synuclein proteins, forcing them to adopt its toxic misfolded shape. Through this transsynaptic propagation, the pathology ascends. It travels up the vagus nerve from the gastrointestinal tract and backward through the olfactory tracts, steadily infiltrating the lower brainstem. This histological section of the substantia nigra shows the result of the invasion. These dark brown inclusions are Lewy bodies. The surrounding pink tissue's lack of pigmented cells proves the extensive death of dopaminergic neurons, causing a catastrophic drop in baseline dopaminergic tone. This anatomical progression dictates the patient's timeline. The deterioration of the gut and the olfactory bulb explains why chronic constipation and a loss of smell frequently precede movement disorders. To understand why a lack of dopamine causes tremor and rigidity, we must look at the basal ganglia. This subcortical network acts as a dual-pathway push-pull control system that filters and refines voluntary movement. The green loop is the direct pathway. When the cortex signals the striatum, it initiates a sequence that clears the thalamus to execute movement. It is the brain's neurological accelerator. Running parallel to this is the indirect pathway, marked here in red. It routes through the subthalamic nucleus and the globus pallidus interna, or GPI. This pathway suppresses thalamic output, acting as the brain's brake. Dopamine from the substantia nigra stabilizes the system, binding to D1 receptors to excite the accelerator and D2 receptors to inhibit the brake. But when Lewy bodies destroy the substantia nigra, that dopamine input vanishes, destabilizing the balance. Without dopamine inhibiting the D2 receptors, the indirect pathway fires out of control. The subthalamic nucleus and GPI become severely hyperactive, bearing down on the thalamus and excessively suppressing motor signals returning to the cortex. The cardinal motor symptoms of Parkinson's are not caused by muscle weakness. They are the mathematical consequence of the brain's neurological brake being permanently engaged. The pathology of Parkinson's maps onto its clinical presentation, allowing physicians to track the disease through a predictable timeline. It begins with the premotor prodrome. Because the gut and olfactory bulb are compromised first, patients frequently present with anosmia, chronic constipation, and REM sleep behavior disorder, where patients physically act out their dreams. The mid-stage of the disease begins when Lewy bodies infiltrate the midbrain, depleting the brain's dopamine reserves and triggering the onset of motor symptoms. This triggers the classic motor triad: an asymmetric resting tremor, cogwheel rigidity during passive limb movement, and bradykinesia, a slowing of voluntary movement. A formal clinical diagnosis requires the presence of bradykinesia combined with either the characteristic rest tremor or rigidity. Physicians must also rule out atypical Parkinsonisms like MSA or PSP. These conditions present with red flags that Parkinson's does not, such as early, frequent falls or vertical gaze palsy. Modern diagnostics now include the seed amplification assay, or SAA. This biomarker test detects misfolded alpha-synuclein with high specificity, allowing for a definitive diagnosis based on pathology. If the dopaminergic deficit must be verified, a DAT scan can visualize the reduced uptake in the striatum, specifically in the posterior putamen, confirming the loss of dopamine-producing terminals. Diagnosing Parkinson's is a matter of observing a decades-long biological timeline rather than just spotting a tremor at a single point in time. Pharmacological therapy has one primary goal: to artificially restore the lost dopaminergic tone and disengage the basal ganglia's overactive brake. The gold standard is levodopa, an amino acid precursor that crosses into the brain and converts directly into dopamine. It is the most effective symptomatic treatment, particularly for elderly or severe cases. Levodopa is always combined with carbodopa. Carbodopa prevents levodopa from breaking down in the bloodstream, ensuring it crosses the blood-brain barrier before converting into dopamine. This flowchart illustrates common strategies. Levodopa is used for advanced cases, while younger or milder cases start with MAO-B inhibitors or dopamine agonists. Over time, levodopa's therapeutic window narrows. Patients experience motor fluctuations, oscillating between on periods of mobility and rigid off periods. As dopamine receptors become sensitized to these fluctuating drug levels, patients may develop dyskinesias, involuntary writhing movements that occur at the peak of a medication dose. When these treatment-induced dyskinesias emerge, amantadine is used to suppress the involuntary movements without worsening the underlying Parkinsonism. While medication can balance the circuitry, it cannot stop the progression of alpha-synuclein pathology. Eventually, the misfolded proteins spread beyond the basal ganglia and into the cerebral cortex. This cortical spread leads to Parkinson's disease dementia and autonomic failure, where the nervous system can no longer regulate blood pressure, leading to profound orthostatic hypotension. Managing Parkinson's is a continuous mathematical balancing act. It is a struggle to maintain the brain's circuitry against a progressive systemic invasion that ultimately redefines the entire nervous system.